we're saying that immediately the abdominal sympathetic trunk gives 3 to 4 lumbar splenic nerves, which pass to the intermesenteric, inferior mesenteric, and superior hypogastric plexus, conveying presynaptic sympathetic fibers to the associated prevertebral ganglia. The cell bodies of postsynaptic sympathetic neurons constitute the major prevertebral ganglia that cluster about the roots of the major branches of the abdominal aorta. The roots of the major branches of the abdominal aorta, the celiac, aortico-renal, superior mesenteric, and inferior mesenteric ganglia, and minor unnamed vertebral ganglia that occurs within the intermesenteric and superior hypogastric plexuses. The synapse between presynaptic and postsynaptic neurons occurs in the prevertebral ganglia. Postsynaptic sympathetic nerve fibers pass from the prevertebral ganglia to the abdominal viscera throughout the periarterial plexuses associated with the branches of the abdominal aorta. Sympathetic innervation in the abdomen, as elsewhere, is primarily involved in producing vasoconstriction. With regard to the digestive tract, it acts to inhibit, slow down, or stop peristalsis. Visceral afferent fibers conveying pain sensation accompany the sympathetic visceral motor fibers. The pain impulses passing retrograde to those of the motor fibers along the splenic nerves to the sympathetic trunk, and then through wide rami communicates to the ventral rami of the spinal nerves, and then into the dorsal root to the spinal sensory ganglia. The parasympathetic part of the autonomic nervous system in the abdomen consists of anterior and posterior vagal trunks, pelvic splenic nerves, abdominal autonomic nerve plexuses, periarterial plexuses of nerves, intrinsic, which is enteric parasympathetic ganglia. The nerve plexuses are mixed, share with the sympathetic nervous system, and visceral afferent fibers. The anterior and posterior vagal trunks are the continuation of the left and right vagus nerves that emerge from the esophageal plexus and pass through the esophageal hiatus on the anterior and posterior aspects of the esophagus and stomach. The vagus nerves convey presynaptic, parasympathetic, and visceral afferent fibers, mainly for unconscious sensations associated with reflexes to the abdominal aortic plexuses and the periarterial plexuses, which extend along the branches of the aorta. The pelvic splenic nerves are distinct from other splenic nerves in that they have nothing to do with the sympathetic trunks, derived directly from the ventral rami of spinal nerves S2 through S4. Convey presynaptic parasympathetic fibers to the inferior hypogastric plexus. Presynaptic fibers terminate on the isolated and widely scattered cell bodies of postsynaptic neurons lying on or within the abdominal viscera, constituting intrinsic ganglia. The presynaptic, parasympathetic, and visceral afferent reflex fibers conveyed by the vagus nerves extend to intrinsic ganglia of the lower esophagus, stomach, small intestine, in ascending and most of the transverse parts of the colon, including the duodenum, those conveyed by the pelvis splenic nerves supply the descending and sigmoid parts of the colon, rectum, and pelvic organs. With respect of the digestive tract, the vagus nerve provides parasympathetic innervation of the smooth muscle and glands of the gut, and as the left colic flexure, the pelvic splenic nerves provide the remainder. The abdominal autonomic plexus are nerve networks consisting of both sympathetic and parasympathetic fibers that surround the abdominal aorta and its major branches. The celiac, superior mesenteric, and inferior mesenteric plexuses are interconnected. The prevertebral sympathetic ganglia are scattered among the celiac and mesenteric plexuses. The intrinsic parasympathetic ganglia, such as the mesenteric plexus, and the muscular coat of the stomach and intestine are the walls of the viscera. The celiac plexus surrounding the root of the celiac arterial trunk contains irregular right and left celiac ganglia. They unite superior and inferior to the celiac trunk. The parasympathetic root of the celiac plexus in a branch of the posterior vagal trunk that contains fibers from the right and left vagus nerves. The sympathetic roots of the plexus are the greater and lesser splenic nerves. The superior mesenteric plexus and ganglion or ganglia surrounds the origin of the SMA. The plexus has one median and two lateral roots. The median root is a branch of the celiac plexus, and the lateral root arises from the lesser and least splenic nerves, sometimes with a contribution from the first lumbar ganglion of the sympathetic trunk. The inferior mesenteric plexus surrounds the inferior mesenteric artery and gives off shock to its branches. It receives a medial root from the intermesenteric plexus and lateral roots from the lumbar ganglia of the sympathetic trunks. An inferior mesenteric ganglion might also appear just inferior to the root of the inferior mesenteric artery. The intermesenteric plexus, part of aortic plexus, nerves between the superior and inferior mesenteric arteries. It gives rise to renal, testicular, and or ovarian and ureteric plexuses. The superior hypogastric plexus is continuous with the intermesenteric plexus and the inferior mesenteric plexus, and lies anterior to the inferior part of the abdominal aorta. At its bifurcation, right and left hypogastric nerves join the superior hypogastric plexus to the inferior hypogastric plexus. The superior hypogastric plexus supplies nerve ureteric and testicular plexuses and a plexus on each common iliac artery. The inferior hypogastric plexus is formed on each side by a hypogastric nerve from the superior hypogastric plexus. The right and left plexuses are situated on the sides of the rectum, uterine, cervix, and urinary bladder. The plexuses receive small branches from the superior sacral sympathetic ganglia and the sacral parasympathetic outflow from S2 through S4 sacral spinal nerves, which is pelvic parasympathetic splanchnic nerves. Extensions of the inferior hypogastric plexus send autonomic fibers along the blood vessels which form visceral plexuses on the wall of the pelvic viscera. The arteries of the posterior abdominal wall. Most arteries supplying the posterior abdominal wall arise from the abdominal aorta. The subcostal arteries arise from the thoracic aorta and distribute inferior to the 12th rib. The abdominal aorta, approximately 13 centimeters in length, begins at the aortic hiatus in the diaphragm at the level of the T12 vertebra and ends at the level of L4 vertebra by dividing into the right and left common iliac arteries. The left of the aortic bifurcation is 2 to 3 centimeters inferior and to the left of the umbilicus at the level of the iliac crest. The common iliac arteries diverge and run infralaterally following the medial border of the psoas muscle to the pelvic rim. Over here, each common iliac artery divides into the internal and external iliac arteries. The internal iliac artery enters the pelvis. Its course and branches are described in Chapter 3. The external iliac artery follows the iliopsoas muscle just before leaving the abdomen. The external iliac artery gives rise to the inferior epigastric and circumflex iliac arteries that supply the anterolateral abdominal wall. Relations of the abdominal aorta from superior to inferior. The important anterior relation of the abdominal aorta are such celiac plexus and ganglion, also the body of the pancreas, also the splenic and left renal vein, also the horizontal part of the duodenum, the coils of the small intestine. The abdominal aorta descends anterior to the bodies of T12 through L4 vertebrae. The left lumbar veins pass posterior to the aorta to reach the IVC. On the right, the aorta is related to the azygous vein, Kyle cistern, thoracic duct, right cross of the diaphragm, and right celiac ganglion. On the left, the aorta is related to the left cross of the diaphragm and the left celiac ganglion. Branches of the abdominal aorta. The branches of the abdominal aorta might be described as visceral or parietal and impaired or unpaired. The unpaired visceral branches arise at the following vertebral levels: celiac trunk T12, SMA L1, inferior mesenteric artery L3. The paired visceral branches are at the suprarenal arteries L1, renal arteries L1, gonadal arteries, the ovarian or testicular arteries L2. The paired parietal branches are the subcostal arteries that enter the abdomen posterior to the lateral arcuate ligaments with the subcostal nerves T12. Inferior phrenic arteries that arise just inferior to the diaphragm. lumbar arteries that pass around the sides of the superior four lumbar vertebrae. The unpaired parietal branch is the medial sacral artery that arises from the aorta and its bifurcation. Vein of the posterior abdominal walls. These veins of the posterior abdominal wall are tributaries of the IVC, except for the left testicular or ovarian vein that enters the renal vein before entering the IVC. The IVC, the largest vein in the body, has no valve except for a variable, non-functional one at its orifice in the right atrium of the heart. The IVC returns poorly oxygenated blood from the lower limbs, most of the back, the abdominal walls, and the aminopelvic viscera. Blood from the abdominal viscera passes through the portal vein system and the liver before entering the IVC through the hepatic veins. The IVC begins anterior to the L5 vertebra by the union of the common iliac vein. The union occurs approximately 2.5 centimeters to the right of the median plane, inferior to the bifurcation of the aorta and posterior to the proximal part of the right common iliac artery. The IVC ascends on the right sides of the body of the L3 through L5 vertebrae and on the right psoas major to the right of the aorta. The IVC leaves the abdomen by passing through the cava foramen in the diaphragm to enter the thorax. The abdominal part of the IVC, approximately 7 centimeters longer than the abdominal aorta, collects poorly oxygenated blood from the lower limb and non-portal blood from the abdomen and pelvis. Almost all the blood from the digestive tract is collected by the portal system and passes through the hepatic vein to the IVC. The tributaries of the IVC correspond to branches of the abdominal aorta. Common iliac veins formed by union of the external and internal iliac veins. Third, L3 and fourth, L4 lumbar veins. Take a look in your atlas. The lymphatic drainage of the posterior abdominal wall and lymphatic trunks of the abdomen. Take a look the collateral routes for abdominal pelvic venous flow and the veins of the posterior abdominal wall. The pulsations of the aorta and abdominal aortic, right? The surface anatomy of the abdominal aorta, the branches of the abdominal aorta, right? Take a look at them so you can see how they're coming along in your atlas. The right testicular or ovarian vein, the renal veins, the ascending lumbar azygos hemiazygos veins, the right suprarenal vein, the inferior phrenic veins, the hepatic veins, the left testicular or ovarian vein, and the left suprarenal vein usually drain into the left renal vein. The ascending lumbar and azygos veins connect the IVC and SVC either directly or indirectly. The lymphatics of the posterior abdominal wall, these lymphatic vessels and lymph nodes lie along the aorta, IVC, and iliac vessels. The common iliac lymph nodes receive lymph from the external and internal iliac lymph nodes. The lymph from the common iliac lymph nodes passes to the lumbar aortic lymph nodes. The lymph from the digestive tract, liver, spleen, and pancreas passes along the celiac and superior and inferior mesenteric arteries to the pre-aortic lymph nodes uh, scattered around the origins of these arteries from the aorta, efferent vessels from the nodes from the intestinal lymphatic trunks, which might be single or multiple, and participate in the confluence of lymphatic trunks that gives rise to the thoracic duct, the lumbar, which are aortic lymph nodes, lie on both sides of the aorta and IVC. These nodes receive lymph directly from the posterior abdominal wall, kidneys to ureters, testes or ovarian uterus, and uterine tubes. They also receive lymph from the descending colon, pelvis, and lower lymph nodes, efferent lymphatic vessels from the large lumbar lymph nodes from the right and left lumbar lymphatic trunks. The inferior end of the thoracic duct lies anterior to the bodies of the L1 and L2 vertebrae between the right crus of the diaphragm and the aorta. The thoracic duct begins with the convergence of the main lymphatic ducts of the abdomen, which only in a small portion of individuals takes the form of the common defect, then will sac of dilation of 5 cisterns. 5 cisterns vary greatly in size and their shape, and usually there is a simple plexiform convergence of this level of the right and left lymphatic trunks. The intestinal lymph trunk or trunks and a pair of descending thoracic lymphatic trunks which carry lymph from the lower 6 intercostal spaces on each side. Consequently, essentially, all the lymphatic drainage from the lower half of the body, the lymphatic drainage inferior to the level of the diaphragm, and all superficial drainage inferior to the level of the umbilicus converge in the abdomen to enter the beginning of the thoracic duct. The thoracic duct ascends through the aortic hiatus in the diaphragm into the posterior mediastinum, where it collects nephritum and visceral drainage, particularly from the left upper quadrant of the body, and ultimately ends by entering the venous system at the junction of the left subclavian and internal jugular veins, which is the left venous angle. And with this, we finished the section 2, which is the abdomen. Right? We have already finished the section 1, which was thorax, and now we're finishing the section 2. And really, after this, there is really not much to learn. This is a descriptive method in which we're taking in consideration the systemic, right, and regional, so we can interact all the knowledge we have acquired along our anatomy studies or medical sciences in order to understand the human body and its functions in a better way. So we can provide whether tutorials, lectures, or patient care, right, at the right time. And we cannot spend the entire life, although when people decide to have the specialty and in a specific discipline, right, people becomes a little bit more aware of probably extra little imaginations, extra bodies, bones, cartilage, innervations, and extra something, right? Because each body has its own anatomy. whether because people walk, whether because people drive, whether because people fly or use the airplane, and the ways people live their lives, how the body develops around the vertebral column, right? And that's how we find different things, overgrown organs. We find arteries probably smaller size than expected because the way people live and the way they move around their bodies and what they do with it, right? And that's the reason that we see that probably when people going to the specialists and doctors in a specific discipline, eventually they find many things, but I mean, we cannot extend more than what is basic. Taking off the holidays, taking off all the vacations, taking off Saturdays and Sundays, understanding that it's just 60 minutes lecture, right, per discipline taken at the school, understanding that people have to memorize once and for all to get ready for testing, right, understanding the jargon and go by to see the resources of each one of the patients. It really takes time because you have to go to the hospital after going to school, and the hospital is not just right beside the school. You waste your time going to different places from your house to pick up your friends, which are going to take a car to save time to go different places in order to learn more. So that's the reason we believe that what is basic will be, and to pay attention, right? And to check the book and to review it and write in your book, in your notes, what you think is interesting and what would you like to go and learn a little bit more during your vacations, during your Saturdays, during your Sundays, during your holidays, right? And that way you will be finding a little more space to clear the questions that you have. But the basic thing is this, and there is really nothing else that you have to worry about. A lot of people which are already graduated and they became a really bright teachers, lecturers, tutors, a lot of them were not able to have a book. They were not able to purchase the book. They were not able, not even to pay in advance to order the book. 20 years ago, it was a dream to have a discipline from medical training. All the MDs went through a lot of hardships, having a book in their hands. And therefore they had to just take a hand, all the notes, and sometimes books in another languages, and didn't have another choice but just to get a dictionary on the language the book was written and just go from there. And a lot of people will never know what it takes and how many things are basic because they didn't have this book. They didn't have the discipline. The book for the discipline they were taking, and still with all their efforts, with all their notes, taking good care of asking the questions after the lecture was over, right? They were able to succeed in the discipline. But once when the person was able, once when the student sees that just what is explained, which is basic by the lecturer, right, by the teacher, and the certain medical training level, right? Then we see what is basic, what it has to be learned and memorized, right? If you can memorize. Therefore, this is it for the section 2 in abdomen, right? We are going to be posting later our own images and drawing from everything related to different kinds of anatomies, but mainly people had to have an atlas, right? Our library, right, is the research that we have, that we're speaking, that we're telling you, which is to nurture the community's curiosity, and for some students who can be able to put hands on a textbook, right? By having something, right, to help them out. Meanwhile, they go and purchase their book or search for a book they really need, right? It's something very important to have pictures, to have drawings, to have what you can put your hands on, so you can learn your chapters, your sections, and that way you can pass your discipline, right? Well, let us just leave over here this